Are you okay with me starting? Okay. Well, good afternoon, everyone. Welcome to Grand Rounds. Apologize for the little delay. Our speaker was driving from Nationwide and ran into some unexpected traffic and then road construction and all the great things that you find on I-70. So we just appreciate her getting here, coming here, and being here. I want to remind everyone that's on Teams, please make sure that you mute yourselves when you join us. Don't hit mute all, just mute yourself. And then at the end, when we have Q&A, feel free to go ahead and just unmute yourself and ask your question, because we don't always get to all of the chat. We run out of time. So again, just feel free to unmute yourself at the end and ask your questions. We are super excited to have Dr. Wilson here, and I'm going to let Dr. Madsen take over because he's going to do the introduction. Oh, I forgot a very important thing, the session number, 211. So that's what you want to text to Cloud, 211. Okay, thanks a lot for joining us.
Okay, I'm going to talk extra fast in the sake of time. Today, we have the pleasure of hearing from Dr. Sheria Wilson, who is visiting from down the road at Nationwide Children's Hospital in Columbus, where she has dual joint appointment as an assistant professor for the Department of Pediatrics in the Division of Neonatology. Dr. Wilson obtained her Doctor of Medicine at the University of Louisville School of Medicine in 2007 and went back to school to obtain a Master's of Arts in Bioethics at Ohio State University in 2018, where she had previously completed her pediatric residency in 2010 and neonatal perinatal medicine fellowship in 2013. She has assisted in bioethics curriculum development at Ohio State University and has multiple publications in peer-reviewed journals and co-authorships of book chapters on various bioethics topics. Please give a warm Dayton Children's welcome to Dr. Sheria Wilson.
Thank you. Can you hear me okay? I appreciate everyone coming in person and virtually. So yes, I am a glutton for punishment. I went back to school and got more education on ethics, and I also teach bioethics in the summer session. Just started at OSU, so I also teach that as well. All right, so I'm gonna make sure all the devices are working. Okay, so I actually worked with Ashley Fernandez, who used to work here. So shout out to Ashley. Maybe he's listening online. We do lots of research and education with the residents and fellows at Nationwide about ethics. So this inspired me to talk about one of the ethical issues that I deal with in my world of neonatology. So we're going to talk about trisomy 13 and 18. We're going to do a review of the ethical considerations related to offering surgery and critical care interventions to newborns with trisomy 13 and 18, or 18 and 13, whichever order. I have no disclosures or conflict of interest. All right, so here are my objectives. We'll talk about the history of medical care of newborns with trisomy 13 and 18. Then we're going to move on and review the incidence of surgery and critical care in these infants. There's lots of research on that. And then we're going to delve into ethical issues and dilemmas and analyze some of the ethical frameworks to help us make decisions when it comes to taking care of children with trisomy 13 and 18. Okay, so make sure they're lining up. So medical advancements have significantly improved the survival. Echo. Hello, virtual friends. You got it? Okay. It happens. Medical advancements have significantly improved the survival rates of newborns with trisomy 18 and 13. However, this progress has led to complex ethical challenges for physicians and medical providers, as well as empowered parents with parental decision-making authority is what we'll say. You might also see the literature say autonomy, which is kind of a misnomer. So in the US, we tend to lean towards involving the parents, which you should, in decision-making. So then we're faced with what to do next or what the next steps are. So this is less arduous when there's agreement between the treatment team and the parent or guardian or whomever's going to take care of the baby. But when there's a lack of agreement or lack of consensus, this can lead to moral distress and sometimes disappointment and just overall difficulty in trying to figure out the steps going forward. So there has to be a way that we can balance the medical advancements that we have the ethical principles, and then also encompassing parental decision-making authority. So we're going to try to tie all those things together in these next couple of slides. So first, we'll just go over a brief history of the medical care of trisomy 13 and 18. So of the major trisomies, trisomy 13 and 18 are the second most common. So 18 actually is the second most common, also known as Edwards syndrome, followed by trisomy 13. And varying articles state different incidences of how common they are. Sometimes they say there's 1 in 4,000 fetuses, and then there could be 1 in 1,500 newborns. And trisomy 13 is about the same as the 1 in 5,000. I said 1,500, 5,000 newborns. Regardless, we see them, and it's difficult to actually quantify how many babies are born with these trisomies because there's a high rate of fetal loss, and then there's significant mortality after they're born. So it's kind of hard to keep track of all these things. So, but when you account for the frequency of elective terminations of pregnancies, stillbirths, and live births, so if you include them all together, the combined total prevalence is approximately 1 in 1,800 total births. So that makes the experience of a family having a fetus or baby with either condition a common event, if you think about it, 1 in 1,800. And then in the US alone, more than 2,000 families experience the pregnancy and or birth of a baby with trisomy 13 or 18 annually. So, no, giving away all the good stuff. Okay, so we do know that survivors of the disease initially, when we first start to learn about them, they have profound neurodevelopmental outcomes and congenital anomalies, which my picture gave away. And most in the medical community considered trisomy 13 and 18, as well as 21, trisomy 21 or Down syndrome, incompatible with life, which I'm saying that in quotes. I don't say it every day, but it's a bad thing to say. Don't say that. Leading to a focus on just comfort care only. So if you're in the medical world, you pull out your textbook and you're studying, these are the kind of pictures that you see. So these early depictions and medical images significantly influence how the medical community treated these babies. So if you look at these pictures, they depict kind of the more severe physical anomalies. I tried to keep them not as kind of I didn't want to cause too much stirring with these depictions, so I kind of picked the less ones that are seen. But if you look at them, I mean, they highlight the severe physical anomalies. So you have cleft lip, extra fingers and toes. They have the proboscis of the nose, and kind of some eye abnormalities, or actually that baby has lack of eyes, and then just the clenching hands. So all these things they don't bring you to think that these babies would survive very, very long. So when we see these images, that's just what we think of the medical community. So that led to us practicing withholding of interventions. It's also known as denial of treatment. So if you hear terms like lethal and incompatible with life, you're not going to offer interventions to these children. So the term denial of treatment was used to describe this approach. And it actually dates back to there's papers from Dept in 1973 that describe this, as well as any babies with congenital anomalies, and as well as the more common ones, trisomy 21 or Down syndrome. So there's many studies where they looked, or those previous earlier studies where they looked at the treatment of those babies in the NICU, and essentially the providers didn't offer any care, and they essentially succumbed to their to the natural course of their disease. So the initial approach in the mid-1900s was to, when they was diagnosed, it kind of led to the self-fulfilling prophecy. Okay, if we think that they won't survive, then there's no point in intervening or offering them any treatments. But if you actually consider intervening and offering things, then who knows what happens. So in the last 3 decades, more and more physicians are resuscitating these neonates. So in a 2007 survey of neonatologists, so some people in my world, 44% of them would initiate resuscitation of a term infant who had confirmed trisomy 18, as well as confirmed cardiac disease. And then a review from 1994 to 2009 found that infants with trisomy 13 and 18 who were diagnosed prenatally were more likely to forego intensive care, as opposed to infants diagnosed shortly thereafter. So if the medical team and the family knew about it before, then they would likely not intervene or offer any therapies after birth. But as time moved forward, there's a shift from non-initiation or of care, non-intervention, towards management and intervention. So in recent decades, there's been a paradigm shift, and they tend to say this, that just due to advances in medical treatment. So we have surfactant. In my world, we have other things such as ventilators and feeding tubes and things like that. So all these advancements have just led to, actually, if you intervene and provide this care for these babies, then their outcomes will change. So over time, evidence emerged showing that some medical and surgical interventions can improve survival rates and the quality of life for children with trisomy 13 and 18. And many studies highlight that the longer life could be accompanied by what people think of as a good life. I mean, even if it was short, it still had the quality of being good per the family's perspective, which contradicted earlier assumptions that it's lethal and it's not a good life. So now they're offering cardiac surgeries and other interventions, and this is improving the survival rates. So the Pediatric Care Consortium. So this study is from looking at patients who had cardiac surgery between 1982 and 2008. They looked at 171 patients with varying degrees of success, and they found that those who underwent surgery had an improvement in outcome. And then the study from the Society of Thoracic Surgeons, that national database, they looked at a time frame from 2010 to 2017, and they looked at 343 operations on patients with trisomy, either 13 or 18. And they showed that the surgeries, even though they were rare, because at that time people weren't offering those interventions, they were becoming more common, and that the mortality rates in these cases were still higher than in patients with the other trisomies, but some of the survival rates were improving. So it kind of showed you, like, oh, if you intervene and maybe the patient underwent a higher risk surgery, they might not survive, but there still were some patients who actually did. So a little bit of improvement. And then there was a study from 2006 that demonstrated that technological interventions could significantly improve outcomes of children with trisomy 18. So then that marked kind of the turn of, let's move forward and offer more treatment. My computer is trying to talk to my watch. So let's talk about the medical and surgical interventions. So surgical interventions in trisomy 13 and 18, they primarily address congenital heart disease. So if you go and do your research, and like I did, and find information on interventions for babies diagnosed with trisomy 13 or 18, it's mostly about cardiac interventions. So this is because congenital heart disease is common. So depending on where you read, it can be between 38 to 45% of babies born with trisomy 13 or 18 have congenital heart disease. And then some of the common anomalies are some of the things that we already know: septal defects, so atrial septal defect, the VSD, ventricular septal defect, and PDA. And then the most common procedures are to repair these things. So those are typically considered to be low risk, but some of the surgeries that are also offered are more complex, such as a Norwood procedure, that's for single ventricle heart defects, and then as well as corrective surgeries for tetralogy of Fallot. So not only were they getting what some people would term lower risk procedures, but also high risk procedures. So looking at a review from Nelson, it's published in 2012, they also commented not only are these children having interventions for their cardiac diseases, they're also having other interventions. So this study was from 1997 to 2009, and they found that a significant number of the patients were also undergoing tracheostomy. So that varied between 2 to 5% of the patients in this particular study. Orthopedic procedures, so we know they have limb anomalies, maybe some limb lengthening or something to do with the digits to help improve mobility. That was about 5%. And then as well as the cardiac procedures were between 4 to 7%. And then 1/3 of those patients who underwent all these interventions actually lived 1 year longer than when compared to patients who didn't have any of these interventions. So this just highlights that the population is living longer once they undergo more invasive procedures. But you also have to consider that now you have more questions. So questions like, if the patients undergo high-risk treatments, how do you know whether the high-risk cardiac surgeries are the low to moderate risk surgeries in patients? Like, how do you know which ones have more underlying complications? Was it due to the fact that they actually have a more complicated heart defect, or was it the fact they underwent procedures and more high-risk surgeries? So then that leads to, here we go. Okay. So that leads to what actually are the outcomes when children with trisomy 13 or 18 undergo these surgical interventions. So recent data indicates improved survival rates and quality of life following cardiac surgery. So like I said, there's many. I just pulled the more recent ones. I was going to include a side of one where they actually did kind of a consensus of all the literature out there, but it was kind of a busy slide. So I just pulled out some of the more significant ones. So in the study from 2008, they found that intensive cardiac management led to survival beyond the neonatal period. And some of the procedures showed a survival rate as high as 91% to discharge. So not only were they surviving, they also were surviving to discharge to go home, which is important. But this author did note that surgical complications are substantial, so you have to be careful with what type of procedure you're going to provide for the patient that they'll likely benefit from the procedure. And then in 2016, Meyer and colleagues just stated that while the majority of children with trisomy 13 and 18 still die in the neonatal period, they found that the risk of death decreases after 3 to 6 months of life and again after 1 year of life. So they were living longer. And then there was one mention of an article back from 1981, that's a good year, that stated cardiac surgery for children with these trisomies have also shown that some of the patients live until their teenage years. But I couldn't find anything more recently, so everyone kept quoting that same paper. So it'd be interesting to see what the long-term outcomes are. And that's what basically all the papers state is we need some more long-term follow-up and information of what happens later. And as well as you have to account for all the different types of trisomies, mosaicism, all the things. Then there was one more study in 2018 that just found that parents who chose for their children to have cardiac interventions reported that they had higher quality of life and satisfaction compared to those who opted for a palliative care only. And then this study from Cooper in 2019, it's just from the Society of Thoracic Surgeons, it just also noted just some more recent data that looking at the congenital heart surgery database, it just showed improvement in survival rate and discharge rates compared to those who did not have surgery. So just the variability of all these cardiac lesions and then the other non-cardiac comorbidities kind of just complicate this risk-benefit balance and kind of makes you try to figure out what should we offer or what shouldn't we offer. All right, making sure my slides ready. Okay, so Annie Javier is lovely. She's from Canada, and then her spouse, Keith Barrington, as well as Barbara Farlow, write extensively about babies with trisomy 13, 18. So I just kind of picked some of the more pertinent articles that kind of sum up some of these things that we've been talking about. So in this particular paper, Dr. Javier and her other authors just noted that a number of factors make the interpretation of reported outcomes after cardiac surgery challenging. So she's like, we can't figure out what exactly all these things are and how we can provide follow-up to these patients. So she noted that there's dissimilarities in practice that lead to a wide variation of outcomes. So, I mean, we all know if you have cardiac surgery here at Dayton Children's, if you had cardiac surgery at Nationwide Children's or somewhere else, depending on who the surgeon is and what procedures that they're feel comfortable with, you're going to have a wide range of kind of what the outcomes are going to be. And then, as we also know, we tend to kind of wait for cardiac surgery when we can, when the patient's typically older. So sometimes they have to intervene in the neonatal period, but mostly the children are older. And that can also skew when should we offer these procedures to these patients. But if they're not surviving to that older age and they're not able to get their interventions, then it also just skews the data. Then the third factor she pointed out was cardiac surgeries just very widely with the risk. And then when you lump them all together, it's kind of hard to sparse out and figure out exactly how you're going to counsel a family on if they should or should not have a cardiac surgery. And then the fourth factor, she just said, cases where cardiac surgery has been withheld is not included in the publication. So we don't get to know what factors or reasons why these patients didn't have cardiac surgery and kind of what their outcomes were. So she basically just concluded that it's unclear whether withholding it on some kids will lead to death or if the death will occur from other causes or other comorbidities that are related to the trisomy 13 or 18. So this is just a chart from that study. This is the only one I included. It's kind of busy. Don't worry, we don't have to read it. It's just the table that basically just kind of lumps all the studies together. And she just notes that there's many patients, there's different cardiac malformations. You kind of can't see the anomalies, but they have basically all the ones I mentioned before, but VSD, ASD, COARC, all the things. They kind of lump them all together, and some of them are from Japan. So majority of them are from Japan in this particular study by Dr. Janvier, but you don't know how to kind of interpret it, especially when they lump them all together and put all the patients with surgery into the denominator, and then you don't know about the other ones. So it's not really that helpful in deciding if a certain child should have an intervention or not, or whether they'll be harmed. But it's data that we would like to know. But at the end of the day, when you look at one individual child with trisomy 13 or 18, it might not be as helpful as we would think it would be. So I'd be remiss if I didn't talk about the NICU, since I'm a neonatologist. So we definitely take care of these patients with trisomy 13 and 18. I want to say that since I've been training, they kind of ebbs and flows. I feel like there's sometimes where there's multiple children who are admitted with trisomy 13, 18, and then there's periods where there aren't. So take that with a grain of salt, but the NICU plays a crucial role in stabilization. So depending on the interventions that patients choose, require or necessitates a NICU stay. So, and the NICU at OSU, I'll use that one because it's our birth hospital that our academic group covers. If the family just opts that they would like a G-tube, gastrostomy tube, then they're going to go to the NICU because our nursery does not do G-tubes. And then also the variations of respiratory support. Some families opt for, CPAP versus intubation versus oxygen, nasal cannula. So depending on what they want, they may or may not end up being in the NICU. So it just depends on what the parents want. So if they opt for more intensive care interventions, they're going to be in the NICU for longer. Some parents go the route of they would like to have more information before they make these decisions, which also necessitates a NICU stay. So at OSU, it's adult hospital, you cannot get certain imaging and things done for babies. You have to go to children's. Fun. And then one of my partners was an author on this CHNC study that was published in 2021. It just looked at the kind of the interventions and intensive care versus medical treatment versus surgery in this group of children's hospitals that we were a part of. There's a total of 36. So this next slide should pop up and show. There we go. So this is the study I was talking about. So it's a cohort study, retrospective trials from 2010 to 2016. So we looked at 3 groups. So ones who received surgical treatment, those who received intensive medical treatment, so NICU stay basically, and then those who opted just non-intensive. I'm just going to go to the nursery, or I'm going to do things that I can do at home. They don't require me to be admitted or hospitalized for a very long time. So they looked at a total of 467 infants, and of those that were admitted to their hospitals, to the NICUs, they noted that 62% received intensive medical treatment, so more than half, and then also of the 467, 27% received surgical treatment. And the most common surgery was, on my previous slide, was gastrostomy tube. And then the survival rate in those who received surgical treatment was 51%. And then, interestingly enough, in those who received intensive medical treatment was 30%. And then non-invasive treatment was 72%. So I guess you just have to individually kind of delve in to see what the intensive medical treatments were and what the actual surgeries were. Were they high-risk surgeries? Were they low-risk surgeries? And then you also have to consider that they're performed at different institutions with different positions and differing standards of practice. Well, not standards, but just how they treat certain diseases and disorders. So they did know that even though they spent more time in the NICU, they were actually able to get these kids home. So they survived a discharge, which is very key. So instead of them kind of having these interventions and then not surviving and dying in the hospital, they actually do get to go home. All right, on to the nitty-gritty, the ethical considerations and frameworks. So I only picked a few because there's many we could talk about. So one of my favorites, that term that everyone likes to use, is the medical futility. So the concept of medical futility, definitely ethical issue in the care of patients with trisomy 13 and 18. So futility refers to, this is the definition that I typically use, interventions that are unlikely to produce any significant benefit to the patient. So if it's not going to do anything, then it would be considered medically futile. So historically, trisomy 13, 18 have been considered lethal. So therefore, I guess you could say that any intervention for them would be deemed futile if you look at the history, but now we know that's different. So this historical context of things being viewed as futile kind of made the decision that we're not going to intervene on these babies. But we know now from discussing the surgical interventions that actually these babies do survive and they do have improved outcomes. So this kind of just challenges that notion that the diagnosis of trisomy 13-18 is futile. So I would be remiss if I didn't talk about the different types of futility. So there's quantitative futility and qualitative futility. So let's talk about quantitative futility. So that's when the likelihood of the benefit is exceedingly low. So there may be some chance, it's hard to say something 0, but it may be close to 0, maybe 5, maybe 10. But that would be kind of quantitative. And then qualitative is where the quality of the intervention or the benefit is deemed insufficient. So in the context of trisomy 13-18, both these definitions were used, and I guess still could be used, to justify non-intervention. But we also have to take into consideration when we talk about medical futility is parental perspectives, because these are their children and they're the ones who are going to tell you about how it's like to have a child with this illness and kind of what the quality of life is. So Anne Javier, again, as I stated before, she does lots of research pertaining to trisomy 13 and 18. So the study she did in 2012, this is just a great quote. 97% of patients with children with trisomy 13-18 are considered their child to be happy and enriching lives. So not that typical, this is horrible, they have poor neurodevelopmental outcomes, they have a poor quality of life is what some people would say. But Dr. Javier says, no, that's not actually what they think. So this just is a reminder that things that we consider to be futile, just from our clinical perspective, is totally different when viewed from the parental perspective. And it just challenges those thoughts of futility. And then Milligan also did a review of futility as well as all the interventions for babies with trisomy 13-18. And Milligan with her colleagues stated that quality of life considerations often differ between clinicians and families, necessitating a balanced approach. So as I already said before, in the medical field, think this is bad. Families may have a different one. So we have to balance that approach and do some shared decision-making and communication. So this just further underscores the need for a nuanced understanding of quality of life, which leads to medical, emotional, and social dimensions that are perceived by us as medical providers and families.
Just a quick question.
Yeah.
With the study that Javier had done, what methodology or what method did they use to assess the happiness? Did they just say, is your kid happy? Was there...
Yeah, it's a lot of surveys, so it's a lot of kind of subjective information. I think there were a few maybe yes or no questions, but it's basically kind of the family is telling you how they feel about things. So it's.
And is it just focused more on like the parent-child interaction or things like their neurodevelopment milestones, things like that?
Oh no, it just touches on kind of the social aspect of kind of how the parents think. I mean, there are studies or other research that tells us kind of what their neurodevelopmental outcomes are, but she more focused on, hey, like life is not that bad. Most of the parental perspectives are survey data, and I mean, it's not shocking to think that, of course, the parents are going to say life is good. I mean, it would be really hard to think that a family, in that state, or maybe they would kind of look back and be like, no, this has been horrible. This isn't great. So, I mean, their life and them taking care of their child is kind of all they know. So I feel like they hopefully would be positive. But I guess I could be wrong. Dr. Javier is like a very staunch advocate for just, we think one thing and we don't ever consider the families, and we have to realize that we aren't taking these kids home, and what we think is bad is not what they would consider to be bad or poor outcome or poor quality of life, to put it in those terms, which quality of life is also subjective within itself. So, okay, yeah. So then when you're speaking of futility, you have to speak about the principle of justice. So justice, one of the 4 principles, and also the burden benefit analysis is kind of what I refer to it as. It just helps us kind of further discuss futility. So the principle of justice dictates that decisions about treatment availability should be based on the feasibility and the ethical permissibility, focusing on overall benefit to the child. So benefit, best interest standard, that could be a whole different dog if we try to sparse those two out. So we'll just look at it from the benefit aspect. So basically, the principle of justice ensures that all children are given equal consideration for treatment, irrespective of their condition. So if someone has full trisomy 13 versus partial or 18 or whichever, that there should be consideration for all the treatment. Not that you should offer them all and do them all, but you should just consider them and think about the child individually. And then this would lead to just informed decision making. So you got to make sure that the parents are informed of all the ethically permissible options. So that's keywords, ethically permissible options. So not, oh, these are all the things we can do. Just pick one. That's not how it works. But we need to make sure that we discuss them and even mention or bring up the ones that the families don't even know to ask. Sometimes it's just overwhelming, so they don't know what's available. And there are some families who don't get on social media or don't go looking for things on the internet to kind of find out what's out there and what's the best way to take care of their child. So this just further emphasizes that we need to make sure that we have good communication with these families, just to make sure that we are going to provide them with the best information, and as well as all the treatment options, and make sure that the providers and the parents are on the same page, as well as providing all the desired goals without putting undue burden or suffering onto the child. So quality of life. So what exactly is quality of life, right? Like, how do we define that? So quality of life, per the technical definition, refers to an individual's overall well-being. So this includes physical health, psychological state, level of independence, social relationships, and the relationship with their environment. So that's basically what Dr. Hanvier talks about when she's talking about quality of life. So those are basically the questions that they ask. So not truly based on neurodevelopmental outcomes or milestones or anything like that. So for children with severe disabilities, you would focus on their ability to experience pleasure, comfort, and then meaningful interactions. And then in the context of the trisomy 18 and 13, the quality of life is crucial because they can also be associated with significant physical and cognitive impairments. So the thought is if they have a better quality of life or better social interactions, they actually might do better. In quotes. So clinicians often focus on objective measures of health and functionality. So this study by Hurley in 2014 just stated the quality of life considerations often differ between clinicians and families. So this just lets us further know that the perceptions can vary widely, they're complex and they're subjective. And then this notion that survival is not the only outcome is very important, and that quality of life is also essential. So not only is just being alive important, but also the quality of that life is also important. Taking into account the ethical complexity of decisions regarding interventions or what to do next for these patients. And then Milligan again, that I mentioned before, that study from 2020, she just states parents' goals should be at the forefront of discussions about treatment options. So that just means that healthcare providers should prioritize understanding and incorporating parental views into the decision-making process. So hopefully people are practicing to share decision-making, but I guess there are some people who could be paternalistic. And then that study from 2018, again, is another survey, just said that they surveyed parents who choose surgical interventions. And of those, they stated, these are with children who just have trisomy 18, they didn't look at 13, reported higher satisfaction and perceived quality of life, and just highlight that the benefits of the medical interventions were aligned with the parental goals. So they want to prove these things, they're going to do the interventions, and it all lined up. That doesn't always happen. And then more recently in 2022, this is when I mentioned before that there's this challenge of not being able to assess the long-term quality of life, like the long-term outcomes. So we don't actually know much about those patients who survive for longer. But data suggests that 12 to 19% of patients with trisomy 13 or 18 survive beyond the first year. And so we should continue to look into long-term care and develop plans with the families. And then the variability in outcomes makes it challenging to predict the quality of life. We don't know what's going to happen. All those comorbidities, types of surgeries, we don't know. There's no way for us to predict. So this uncertainty could just lead to more ethical dilemmas when parents opt to try more what some would consider high-risk procedures for their children. And of course, got to talk about that ethical principle of beneficence. So this requires healthcare providers to act in the best interest of the patient. There's other types of decision making, but we'll just talk about the best interest from the perspective of beneficence. So this would mean you want to aim to maximize the benefits, minimize the harms. So it's just very much needed in this discussion when we talk about life-sustaining treatments for these patients. So it is argued that decisions about treatment availability should be based on feasibility and ethical permissibility. So focusing on overall benefit, and we should just carefully consider the quality of life. And then shared decision making, which just involves collaboration between the parents and the teams, is very important. There's been multiple studies that emphasize physicians and parents collaboratively should collaboratively decide the best outcome of action. And this just approach respects the expertise of the medical professionals, and then as well as respects the knowledge and just the overall condition of the parents, that they have their child's needs and happiness in mind. And then this zone of parental discretion. This is a newer framework that I haven't really heard about until I started working on this talk. It allows parents to make decisions within a range of ethically acceptable options. So when describing this framework, it just notes that the value judgments about anticipated disability are best made by the parents. So that's where they get all those judgments from, is actually interviewing the parents. And so this just further acknowledges the parental role in determining acceptable quality of life. And then the last point is, from all these studies, basically, we need to be cognizant that although we have all the information about all these patients and we know about all the denominator and know about all of them, at the end of the day, they're still an individual person, and we need to work on developing care that is individualized to them instead of looking at all the patients who have that disorder or illness. So there's a quote from a study from McCafferty in 2016. He just states that policies that integrate family-centered care principles are crucial in ensuring that medical interventions align with the values and preferences of families. So parents of children with trisomy 13 and 18 often opt out of intensive care interventions to extend their child's life, emphasize the need for individualized care plans. So that's just to say that we need to just focus on kind of what are we doing for this particular child instead of all of them. So some centers have policies on how you approach patients who, from the start, there's a prenatal diagnosis of these trisomies versus a postnatal diagnosis, and kind of how you can approach each time frame and what things to consider when these patients are born. So I went really fast because I was late, but for the conclusion. So trisomy 13 have been called incompatible with life and lethal. We will not use those terms, but that's what they used to say. And then that would lead us to our self-fulfilling prophecy of doing minimal interventions. So of course the patients didn't survive. So now that there's been advances in surgery and care and other interventions, so we've improved outcomes. And then we do know that parents see the value in their child's life. And then this further just challenges us in the medical field to just think about that more. And then we also have to consider, not only do the patients survive and we want to, like they have to live, but we also want to consider their quality of life. And then when we're looking at the ethical dilemmas and principles, we just need to consider that we need to look at the evidence, look at the child's best interest, and as well consider justice, beneficence, and all of those things. And so I know that I started out and had those pictures from the textbook, but I had to end with the happy pictures of the happy babies that I saw. So I'll date myself. I'm not that old, but we actually had textbooks in med school. So all those textbooks, all those pictures before were from all the texts that I saw when I learned about it. And then actually, progressing on and knowing all the things I know now, it made me really happy when I was Googling pictures to put in my talk about patients with trisomy 18 and 13, that there's happy pictures now. And actually, it's really hard to find a picture that depicts all those more severe anomalies. So I just want to leave you with happy pictures. And I do appreciate that this baby is smiling with their cleft. And there's any questions. And then I have lots of references. I did not want to just put them on a slide, but I can provide a link to my Zotero account and you can read them. So I'll welcome any questions.
Okay, do we have any questions in the audience? I always have one that I like to throw to the
Yep.
ethics folks.
Oop.
So,
Uh-oh.
well, you talked about this. So the difficulty of defining quality of life.
Mhm.
So what is, in your experience and all the things that you've done, what has been the best definition for quality of life you've come across?
Ooh, that's a toughie. So I usually tell the family it's kind of like how, okay, now you know that what you thought was going to be your normal is not your normal. So kind of what, what do you like, what do they care about the most? So there's some families who, if they know that their child will not be able to walk or talk, they're like, that's fine. If their child's only going to live for so long, they're like, I'm just want to take them home. So I kind of ask the family kind of what they're leaning towards, before I just kind of throw out suggestions. But it's also good that we have patient advocates and other ideas that we can have families talk to other families so they can figure out what, what the expectations are that their child could possibly have when they go home, or any complications or anything that occurs when they have the surgical interventions.
Yeah. So I find it varies from person to person, just as you're saying. And so the best kind of general thing I've come across in like the ethics committees I've served on is it's kind of formulaic, but the capacity to love and be loved.
Oh,
Be,
the
and,
basics. The
and
basics.
how you define that. And so, and I think the oldest trisomy 18 patient I've met was in their teens.
Mhm.
And so shocked me. I was like, trisomy 18 because of all the things that
Yeah.
you said. So yeah.
Yeah, I know. And I found that one reference to the case report from the paper from 1981, but I couldn't find I couldn't find any more, if that makes sense.
Yeah.
It's interesting that they live that long, but are they mosaicism? Like there's got to be more to the story.
Yeah, that's essentially in this patient's case, they were a mosaic. So it was not the, I dare say, typical scenario. Dr. Gupta online, it seemed like you have a question. Go ahead. I think you need to unmute. Okay, maybe she doesn't. Any other questions in the audience? All
Hello?
right, thank you. Oh, there she is.
Yeah,
Hi, Dr. Gupta.
sorry. Hi. What I was saying, very excellent presentation for this severely, fatal disease, which was considered before, and now you guys can do something. And my question was the people who undergo all these treatments and also survive this, how long do they survive? I know you said you had met somebody who was 14 years old, but in general, what will be the lifespan or outcome for these patients? That was my question.
Oh, so from all the papers that I was able to read, the average I could see would be 10 or less. There aren't many children that survive beyond the age of 10. And I think it also is hard to actually find the number because there isn't much case report information about it, unfortunately. So it all depends on how much information people are willing to share.
Yeah. Well, thank you. But like I said, it's exciting to see that there's some chance for these kids to live, you know. So thank you.
No, thank you.
Have they differentiated between the untreated survival and their survival? Because, like, we have a child right now in house that's almost 5, but she's tricked, invented.
Mhm.
So, is there any information that differentiates between when you go ahead and do that compared to no intervention?
The only papers I could find were from the neonatal period, so not when they're longer. So there's just a lack of long-term information on what happens after they get discharged. And many of the authors of the papers I read just state, oh, there needs to be more information on long-term outcomes, but no one has either published that or maybe they're still gathering data. So it's the majority of the papers that I read was for the neonatal period, or at least less than 1 year of age.
All right, I think that's it for questions. Thanks so much, Dr. Wilson.
Thank you. Thanks to everyone coming in person and online.
I got to stop the recording.